So you might be asking yourselves, and I rather expect you do have involvement with all these concerns, the public policy process, difficulty with scarce resources like money, your own provider operating policies. All of these issues have been issues that PMC, and indeed I personally, have worked on various healthcare industry projects. I should confess here, you can't see them over the phone, but I have a great many wrinkles. I have been in simulations since the late 70s. The wrinkles are showing after 30 years, and as a veteran, I welcome new, young, eager recruits to the prospect of improvement through simulation. So here are some of the nice things that simulation can do. Give you models, and the models include animation. The animation is a very helpful communicative aid to understand what's going on and communicate your results and communicate your thoughts for improvement. The model can reflect your system structure and any data you can obtain. If some data is missing, it can be estimated and a sensitivity analysis done. So if there's some data you need and don't have, that's not a showstopper. But your results will necessarily be more approximate. But approximate results can be very helpful to determine alternative A is definitely better than alternative B. And that can be valuable information to have. And its simulation is much less disruptive than playing with your real system or turning it off while you make changes to it. You're all no doubt aware of the high amount of variability. Is something as basic as how much time does each patient need with the doctor or with the nurse, or how much time laboratory tests take. There's enormous variability. Closed form methods in the operations research books do not allow analytically for the variability, but simulation does. And you get your results clearly in the form of results, graphs, pie charts, result tables, plus the animation. The value of animation, which I already mentioned, animation is more like a movie than a snapshot. And if you ask yourself colloquially, which is more informative, which conveys more understanding, looking at a snapshot or watching a movie? The movie should certainly win. And simulation animation can be like the movie. Now, here's some specific questions, and all of these are questions that my colleagues and I have recently explored for real live clients, not just hypothetical clients. And I think you will all agree as you read these 3 bullet points, and it could have been 8 or 10 or 20 bullet points if we gathered all the studies we've worked on together. I think you'll all agree that these are very important questions in context. It happens the one I'm most familiar with, worked on most recently with a student trainee, was the 3rd one, an in-hospital pharmacy. And it turned out, to speak in generalities, the details are confidential, but the hospital was delighted to discover, as a result of our simulation, that the delivery time could be shortened very cost-effectively, not with more pharmacists, they're quite expensive, but with more what might be called couriers or delivery runners bringing prescriptions to the pharmacy from the hospital wing and vice versa, bringing pills from the pharmacy back to the nurses' stations. So that was a happy discovery through simulation. This particular third item has been written up in a conference application paper that I can provide on request. Anyone who'd like a copy of these slides or where this paper is that I just made reference to after the webinar is welcome to get them. Send me an email and we'll provide. So I hope that as you read this slide, you're thinking of some questions of your own that you'd sure like to get answers to. Now, simulation, and think back to the slide John showed. He's a good, true, red-blooded salesperson. He showed you a slide of many of the things PMC does besides simulation, like work methods, value stream mapping. Simulation is not a technology that exists in a corner off by itself. There is wonderful synergy, first word in the title. There's really effective synergy between simulation and the other techniques available within industrial engineering. Simulation works better along with other techniques and provides proportionately more value. Any of you who have ever played chess know that two rooks working well together are much more powerful than twice one rook working by itself to demolish the opponent's defenses. And similarly, simulation works very well with these other techniques mentioned on these slides, like theory of constraints, ABC, and so forth. Value stream mapping would be another you can think of that would fit here to attack and demolish some of your most knotty problems. So please consider it not by itself, but as one tool in a very big and powerful toolkit. Now, to get these wonderful things, you have to put something in. You have to make an investment, or your organization has to make an investment. And here's what the investment entails. You're already doing number 2. You're donating some of your valuable time to this webinar to get an idea of what simulation can help you accomplish. And I want all of you to think of simulation the way an expert astronomer thinks of a telescope. Simulation is not, repeat, is not a technique that replaces you, the skilled, knowledgeable industrial engineer. In the same way, you cannot replace a skilled, trained astronomer with a telescope. A telescope will not discover anything by itself. What the telescope will do is leverage the expertise of the astronomer. You're all industrial engineer types, thoroughly trained and knowledgeable in the systems where you work and healthcare systems in general. What simulation will do is leverage your expertise on behalf of your organization. Your expertise can learn and discover more by using simulation, just as the astronomer can learn and discover more if he or she has a high-power telescope. So simulation is like your telescope. It lets you see more that you can then use your expertise to understand. And very likely, you all have an appreciation for statistical issues. You know what confidence levels are. You know what variance is and why it's so important. You'll need a software package. When the time comes, we can recommend several. Help you choose if you don't already have one. You'll see a little bit of a demo of how simulation works, what it looks like in a few minutes. A big investment is likely the last one. You may already have some data that you've spent considerable effort to collect. If not, you'll need some data, and the data collection phase is typically one of the bigger parts in both time and people's cost of doing a simulation. Building the model is usually actually quicker. So simulation runs on data. It can make estimates provisionally if you don't have data or don't have it yet. But a simulation result is no more accurate than the data that went in. So the fifth bullet point represents significant effort invested in the virtues of simulation. Now, let's look at a little demo. I'll end the show for the moment, and we'll bring it back to conclude. And here is one of several packages that we support that can do healthcare modeling. MedModel is one of many. It's certainly not the only one, but is meant to model healthcare systems. In fact, it's really the same package as ProModel, in case some of you have ever heard of ProModel. ProModel and MedModel are the same except for the icon library. The icon library of MedModel looks like machines. Now, when you build a simulation using this software tool, that's already been done for this example, you define all your locations, like where the people come in, where the patients wait for attention, where's the laboratory that they may have to go to, where's the office, the delivery room, the recovery room, if you're running maternal care, whatever your locations are. And a location can be defined as a sort of waiting area where many people can wait, or it can be defined as having a certain capacity, like just one patient at a time. After you define your locations, you define your entities. You may have different types of patients. This basic model has only one generic type of patient. But you could have patients of different types, like inpatients, outpatients, and emergency patients. And they could be defined as different types of entities, or they could all be defined as patients with different numerical attributes to keep them separate. Then a key part is the resources, and you'll recognize the names of these resources, no doubt. How many doctors and nurses there are. In a larger model, this might include laboratory technicians, receptionists, orderlies, physical therapists. The possibilities are limited only by your needs and by your imagination and by your knowledge of the system details. And the key, this is the key one, processing. I always say for which entity, at which location, what does it do? Nothing. It just waits. And when it's done waiting, where does it go? The patient at this location does these things, and here are the details. We need the nurse, which is a resource. So we use the nurse for a certain length of time. In the treatment room, in there we're going to need the doctor. And depending on the type of patient, we need the doctor for different lengths of time. In this case, we need the doctor for a length of time that is normally distributed. That's what the capital N means in MedModel. What distribution do you use? That's a weighty statistical question in itself. And here at PMC, we have statistical packages and the expertise in using them that can take numeric data you've collected and recommend an appropriate statistical characterization of your data that accurately captures the randomness, in other words, the variability in the model. And I already mentioned on one of the slides, modeling the variability of the process is a very important requirement to model the process accurately and accurately evaluate the relative merits of proposals for improvement. So these two menus go together. When an entity, like the patient, is in a particular place, like the delivery room, what does the entity do, which is captured in this detail, and when finished, where does the entity go next? That is called the routing in this particular package. And in this small model, there isn't too much more, but here's an attribute. What type of patient is it, which I made brief reference to. We can define variables that are used to track processes and performance of the model in the simulation. If you need to, you can define shifts. If you run continuously, like an emergency room, you may not need to define shifts. In a doctor's office, you might very well want to define shifts in a more complex model. And there are various other niceties of MedModel that the software provides, like the ability to define a user distribution if the standard ones like the normal, the Weibull, the exponential do not fit my data well. I can define a distribution of my own. So there's a great many tools, and all of these tools are used as needed to build a model. And then when the model is built, we can run it, and we get a little comment that you can read here of what the model is. This is a generic example. It is not a confidential client one, certainly. But it shows various things about how to use MedModel. And this slider bar controls the speed of the animation. The animation can be a big help toward understanding what's going on, and it can be a big help toward making corrections as needed into the model. You might show colleagues and managers your first animation and say, oh, the people are going to the wrong places, or why are so many people going to this one place at a certain time. That could detect errors in the model before they infect conclusions to be drawn. So if I speed this up, the animation will go faster. In fact, in the long run, I can turn the animation off completely by moving that slider bar until it's touching the right-hand end. This short model, the animation took very little time anyway. And yes, let's take a look at some results, if they'll work. And good, they are working. Last week this computer had a database problem that was causing trouble, but that seems to have been cleared up. I had systems people look at it. For each location, I can get some very valuable statistics, and I'm dragging, and I'm hitting Control-C, and I'm opening Excel. If that didn't cut and paste, that was our meeting address. Let me try that again. I might have to say copy-paste, but these results can be easily exported into Excel, either within the model or through a copy-paste. My keyboard is stuck momentarily. That's annoying. But here we can, at any rate, see the results in MedModel or ProModel. Notice I'm interchanging them almost without thinking, because in my mind they're alike except for the graphics library. I can see results by task. I can take resources down if I want to. For example, a piece of laboratory testing equipment might go down. I can represent these as various charts, like bar charts. That's very easy to do on MedModel. I can look at my resources. They're expensive, right? The doctor and the nurse. How heavily are they used? We want these utilizations high. We don't want them so high that we have bottlenecks, but we want these utilizations high. Wow, an expensive nurse, maybe we can find something else for the nurse to do, or figure a way of improving our resource utilization by policy. And you'd be amazed what this has shown up in various models. The model I showed you, and I'll bring it back up briefly. I can switch between these two windows anytime I want. But the model I showed you has elements in it that represent how the workers, in this case the doctor and the nurse, walk from point to point. And that is called a path network. And in one interesting study presented just yesterday at the Michigan Simulation Users Group, I was there yesterday, one of the presenters presented a case study on healthcare that said we found that in one shift, our nurse walked 16 kilometers. This was a presentation out of Europe, so it was kilometers, but that's quite a bit of hiking for the nurse. And when the nurse was walking, what was the nurse not doing? What else could the nurse have been doing with a better layout, better procedures, better prioritization, to say nothing of how that much fatigue could certainly make a medical professional very error-prone. And that would be an important issue in simulation. You might not only improve your bottom line, but decrease error rates in a medical sense by improving worker procedures, so the dynamic or fatigue issues. Now to return to our results, here are some of the resources, resource states, and the GoToMeeting thing is covering up the little one-liner where I can click. There's a little one-liner screen to click to make these a bar chart. There's only two here, so it wouldn't show much. But these can be clicked either here or in a bar chart. And this is another menu option for bringing up the bar chart. And it doesn't look like much with just one resource built, but when you have many resources and you want to compare their usage, such bar charts side by side can be very valuable for comparison. So there's a great deal to be learned and observed, even from a very small, this is really a toy model. And think how much more can be learned and evaluated with a full-size model. Now, John has come back, and you may very well have questions. which we will be happy to answer. I think John is going to unmute the telephones. We've had them muted to prevent feedback noise. And going back to slideshow, there was our demonstration. And I always finish with a couple of recapitulation slides. And here's one to help you get started. What do we hope you'll do next? Well, we hope you'll use simulation as a very powerful tool to improve your operations. And here are the steps to doing so. How would you start your first project? Pick an area, and very likely not the whole thing. Pick an area that looks particularly problematical. It might be one section of the clinic or hospital, one department. Start small, especially if the technology is new to you. And have on one sheet of paper a list of questions that you want the model to answer. What do you not know or not know for sure that you would like a model to answer? And those questions should be on a sheet of paper, and the person building the model should have that sheet of paper at his or her elbow the whole time, because the model is good if it correctly answers the questions the client wants answered. It's dangerously easy to rush off mentally and build the wrong model for what needs to be studied. The model may be beautiful, but if it's not helping the client, it's not the right model. Check that you have or can get the minimum of data you will need. Make a strategic decision. Are you going to undertake the project in-house? In other words, develop your own simulation expertise, and we can help. Or are you going to hire it done? If you're going to undertake it in-house, then you need to buy a software. And that would lead to the fifth point. If you do need the software and don't already have it, you'll need to purchase it. We're resellers of some with a support agreement and so forth. And this is always my last slide. Questions and discussion. There's our emails. On behalf of John and myself, thank you all for your attendance.